So these are answers for case number 7 involving 28-year-old female who is G2P2 with history of mild persistent asthma, who delivered a 3.9 kg baby by spontaneous vaginal delivery after prolonged second stage of labor with oxytocin augmentation. 30 minutes after delivery, nursing staff reported that patient is having brisk vaginal bleeding. Estimated blood loss continues to rise despite fundal massage by the nurse. 2 large bore IV lines are placed and blood is sent for CBC and type and cross. Vitals, her blood pressure is low, 88/52. Heart rate is increased to 128. On physical exam, she's tachycardic. Abdominal exam shows uterus is soft but boggy and enlarged above the umbilicus. Examination of perineum shows that perineum is intact. There are no lacerations or hematomas, but brisk vaginal bleeding is noted. Looking at her extremities, her extremities are cool, pale skin, and there is delayed refill. The question is, what is the most likely cause of bleeding? Is it a uterine atony? Is it retained placental tissue? Is it a uterine rupture? Is it coagulopathy? Based on the most common causes for postpartum bleeding, postpartum hemorrhage, it's not coagulopathy, it's not a uterine rupture, it's not a retained placental tissue. The most common cause for up to 70% of the cases is uterine atony, the uterus remaining distended and failing to shrink and contract. Is the correct answer. Question number 2, what is the best next step to control bleeding? Choice A is manual uterine exploration. B is bimanual uterine massage. Choice C is IM methylorgonavin or Methergin. Choice D is emergent laparotomy or hysterectomy. So what is the recommended first step if uterine atony, distension, failing to contract and shrink, if that is the most common cause for postpartum hemorrhage? So the correct answer is bimanual uterine massage, which is B. Question number 3. So if the bleeding persists after the massage, oxytocin is also given. Additional uterotonic or medication should not be used in this patient. Is it carboprost or hemabate? Is it a misoprostol, cytotec? Is it a methylorgonavin or Methergin or a TXA? This patient has history of asthma. Carboprost or hemabate can cause spasm. So we don't want to compromise airways in a patient who already has underlying problem. In a patient that has asthma, we don't want to use a carboprost. Yes, the correct answer. And question number 4, if bleeding persists after uterotonics and TXA are used, what is the next step before hysterectomy is considered? Is it a uterine balloon tamponade? Is it endometrial ablation? Is it DNC or bilateral oophorectomy? So we should avoid any invasive procedure before to give a treatment. We need to avoid all invasive procedures and should start with conservative, mildly safe procedures. DNC is an invasive procedure. Endometrial ablation is also an invasive procedure. And we don't need to remove the ovaries. There's no need for that. So that's also an invasive procedure. Is the correct answer. Uterine balloon tamponade, where a balloon is inserted through the vagina into the uterus. The uterus is compressed, or the wall of the uterus is compressed by a balloon that is expanding. As a result, compressing the blood vessels and stopping with the bleeding. So uterine balloon tamponade is the correct answer. And last question. Massive transfusion is initiated. What is the optimal blood product ratio? just packed red blood cells until hemoglobin is more than 10? Is it 1-to-1 ratio of red blood cells, FFP, and platelet, or is it 2-1 ratio of packed red blood cells, FFP, and cryo, or just giving packed red blood cells and crystalloids? Criteria for massive transfusion is if there is a blood loss more than a liter and a half. The old protocol for massive transfusion is 6-4-1 protocol, 6 units of red blood cells, 4 units of FFP, and 1 unit of platelets. But the current preferred strategy in most level 1 trauma centers and current protocol for a massive transfusion is a 1-to-1 ratio. So 1 unit of packed red blood cell, 1 unit of FFP, and 1 unit of platelet, or a unit of platelet.